Hello all, good evening and welcome to my IVF. We are back with one more webinar tonight and I'm glad that we are back with Dr. Halyna Strelko. Hello, Dr. Halyna, welcome back.
Hello, good evening, nice to see you again.
It's definitely nice to see you again. I'm glad that we are able to speak to you today. Of course, there were some issues, as you said, with electricity yesterday, but we hope that today everything will be fine. So please be aware that if for any reason Dr. Halyna will disappear, we will try to reconnect. Hopefully it's not going to happen, so we will be able to proceed. But of course, there is this possibility still. So just please be understanding, of course. But we are definitely happy to be able to talk about this particular topic. We will talk about poor responders, diminished ovarian reserve, and of course, our expert, Dr. Halyna, will be able to help us, I'm sure, with all of your questions. And before we start, let me just add a few things. So as you know, European Fertility Society is simply here to support you, to give you webinars where you can learn, when you can ask, but also to support anyone that is going through infertility treatment. And also, I just also wanted to say that tomorrow there will be a Fertility Care Awards Gala, which is at 12 and 11 a.m. UK time. So if you are free, if you wish to take a look at some of the winners and see who won those awards, there were definitely lots and lots of the people that actually got into it, then I can only encourage you to go ahead to our website, europeanfertilitysociety.com, and this is where you can find the link to tomorrow's gala. Maybe you will be able to join us. But also, as always, I want to say huge thanks for Phenomatch, as we are proudly supported by them. And as you know, it is really hard to just exist without any supporters like this. And also, as you probably also know, we still are looking for some volunteers. So if you are up for it, right now we are looking for some people that are able to help us with transcriptions. So if you know someone, or if you are someone that can help with that, please get in touch with me, Caroline at europeanfertilitysociety.com, and I'll be happy to give you some more details. And this is just my short introduction, but right now I think that it's time to start and go ahead with our topic. Dr. Halyna, as always, happy to have you back. Ready to start with the presentation?
Yeah, sure. Thank you.
Brilliant. Here's the presentation for you, of course. Thank you.
Thank you. Thank you for your presentation and for your help. And today we should talk about poor responders and how to make IVF cycle more successful in this case, because unfortunately, if patients are poor responders, it is extremely difficult to receive good result in IVF treatment. So let's see the current options, what we can do in case on poor response. So first of all, we should say, what does it mean, poor responder? According to the criteria which was agreed in Bologna, and that's why we call them Bologna criterion, it should be maternal age 40 years or more, or some other factors for poor ovarian response, such, for example, endometriosis or some surgical interventions. Also should be as minimum in some cycles, previous cycles, poor ovarian response, and low antral follicle count and low markers of ovarian reserve. So if we have two from these three, we can say that our patient is potential poor responder. So when we are talking about IVF success, there are a lot of estimation models, the models of prediction, And one of them you can see here, and there are a lot of points. And any mathematic model or predictive model, when we have more than 3 or 4 points, it is extremely, how to say, unstable and difficult to predict finally. So we should see, first of all, the main points which can help us to predict the response and success rate. And in case of poor responders, of course, it is the low number of eggs. So let's see why and which number of eggs we can consider as low. So, which factors the most important to predict IVF success? First of all, it is woman age. And in Bologna criterion, we have seen that age 4 years or more was mentioned as one of the first criterion of poor response. Then it is ovarian reserve. It means oocytes and follicles number. Because each oocyte can give live birth. The estimation percentage is around 6-7%. So more oocytes we have, more percentage we can expect to have. Also oocyte quality, because if we receive oocytes in big number but in poor quality, of course the result will be poor. Possibility of cryopreservation, because if we have cryopreservation, we can do 2, 3, 4 transfers after one stimulation, and in this case cumulative live birth rate and pregnancy rate will be much higher. Also sperm parameters may be important. Existing problem like endometriosis, myoma, endometritis, all this problem can decrease implantation rate. Also number of previous cycles, because if we have several unsuccessful previous cycles, it unfortunately decreases the probability of success in future cycle. And also some laboratory parameters. In this slide, you can see the American Association of Reproductive Medicine results, the pregnancy rate and live birth rate according to the woman's age. And we can see that after 38-40 years old, from the age of 41, the results decreased dramatically, and after 42 years old, became mostly zero. And what is interesting that cumulative live birth rate, of course, even in late reproductive age, depends on existing or absent of cryopreservation. In this slide, you can see that in this study, there was several group of women of late reproductive age, and we can see cumulative live birth rate. In blue, we can see the fresh transfer, and in red, additional pregnancy with cryotransfer. So we can see that more eggs we has, and also if we has frozen embryos, more cumulative birth rate we can expect. And in late reproductive age, in most of case, very few number of eggs, no freezing, and quality of eggs is decreased. That's why the result is so poor. Oh, sorry. Oh, I will move like that. So this is the study. We can see the age groups, 38, 39 years old, 40, 41, 42, 43, and more than 44. And the highest pregnancy rate and cumulative pregnancy rate and results are much better, 38, 39. The difference between 39 and 40, for example, seems not very big, but we can see that the results of treatment are really different. And also important that the results are dramatically increased depending on number of retrieved oocytes. So if we compare even 38 but 4 oocytes and 38, for example, 12 oocytes, we will have more than twice the result. So important to have enough eggs. Also, a good illustration about the importance of number of eggs. You can see in this slide, because according to the number of eggs, if woman would like to have 1 child, 2 child, or 3 child, we can see 1 child, for example. So probability of pregnancy and number of eggs. And you can see that in young age, around 20 eggs can give us the cumulative pregnancy rate around 80-90%. But in 41, 42 years old, 20 eggs, around 40%. But the problem that in most of cases we have no 20 eggs in this age. So this is the most important, which we can understand that age per se, unfortunately, decrease the probability of pregnancy, and number of eggs is very important to improve or decrease this probability. So when we are talking about age limitation, we should say that pregnancy rate is 3 times higher before 39 years old in comparing with 42 and 43 years old. Cumulative pregnancy rate is strongly influenced by total egg number before 43 years old. After 43 years old, the probability of live birth is mostly 0, unfortunately, and not depend on egg number because on very poor egg quality. So better to, how to say, realize all your reproductive plans before the age of 43 years old. Of course, it is individual, of course. Nobody can say for exact patient which is the exact age limit. Some literature articles say that even 45, 46, 47 years old woman can receive the viable pregnancy, but it is very, very rare, and articles say that it is approximately 0.2% of women population. Okay, what about egg quality? What does it mean, egg quality? Poor egg quality, it is one of the main cases of repeated failure in assisted reproduction treatment, even in young age. The quality of eggs is mainly determined by organelles named mitochondria, and they supply energy to cell, and with other factors present in cytoplasm of egg. You can see in this picture how present egg, and all parameters, for example, the thickness of zona pellucida, the peritonian space, some granulation in cytoplasm also may indicate poor or better egg quality and influence on result. So oocytes quality and IMH level, yeah. IMH level and female age, how they are correlate with the pregnancy, yeah. We can see in this slide that if we compare pregnant and non-pregnant women, IMH level is not very different even with high IMH group and low IMH group. The main importance is age and egg quality. The role of this organelle mitochondria during the aging, first of all, the number of mitochondria decrease. Mitochondrial DNA start to mutate, and function of this mitochondria also decrease. There are some structure in chromosome named telomere, and during the oocyte aging, there are influence of this telomere, and it's increased the number of genetically abnormal eggs during the fertilization and further cleavage. Also, some damage of mitochondria increase the probability of abnormal development of embryo and arrest of development. In most of cases, the genetic abnormality, when we are doing PGD test in the late reproductive age, we can see that the main often problem is chaotic abnormality. It means different chromosomes involved, not only one or two, but most of them. So if we can see the increase the proportion of maternal meiotic abnormality during the age of a woman, mostly depends on maternal meiotic abnormality, this red graph. So we can see that most of mechanism of embryo aneuploidy depends on maternal problems. Paternal give only few, from 10 to 20%. So, what is the main goal of controlled ovarian stimulation protocols in poor responders patients? We have two main goals. Yeah, we should influence to egg number and egg quality. Try as minimum. Yeah, egg number. There are different strategies to arrive to this point. So what we can do? We can do egg banking. It means that we can do several egg collections and freezing eggs. We can do what we call duo-stim. It means 2 stimulation in one cycle. We can do what we call pre-treatment. Give some medications which may give more follicles and more oocytes. We can do what we call early start. It means that we start the stimulation from luteal phase or from the early beginning of follicular phase. It may receive more homogeneous cohort of follicles. About egg quality, it is a little bit more difficult because, first of all, we don't know the quality of eggs before we have egg retrieval. So it is difficult to predict. We can influence with different triggering strategies, and in some case it may improve the maturity of eggs. We can use some gentle embryological techniques and also pre-treatments and some scheduling. So now we will talking about different types of poor responders. There are 4 types of poor responders about according Poseidon classification. So group 1, young girl, less than 35 years old with good IMH and good antral follicle number, but with poor ovarian response or poor egg number after egg collection. Group 2, also good ovarian reserve, but age more than 35 years old. Group 3, less than 35 years old, and poor antral follicle count and low anti-Mullerian hormone. And group 4, worse, unfortunately, prognosis, age more than 35 and poor ovarian antral follicle count and low anti-Mullerian hormone. And let's see what strategy we can have with different groups. So first of all, we can see the outcome of assisted reproduction technology in different subgroup of poor ovarian responders. Why it is important? Because different subgroup has different prognosis and little bit different treatment strategy. So group 1 has the more easy to see implantation rate, for example. Yeah, group 1, low implantation, low, but okay, better in all this group, 12%. And lowest implantation rate has group 3 and 4, when we have decreased antral follicle count. Yeah, it is twice less than these two. We can see that statistics say that young age, it is important even with low number of eggs. So what stimulation strategy can we choose? In this slide, we can see several protocols like stop protocol, short protocol, long protocol, luteal phase, follicular phase, natural cycle, mild stimulation, delay, agonists, flare protocol. The problem of all this protocol that there is no one optimal which can guarantee good results in poor responders. That's why doctors and scientists try to find something which can improve their result. So let's move from protocol to pretreatment and then return to protocols. Some pretreatment strategy show better results than other. And in this publication, we can see that, for example, using stimulation strategy as Clomid, it is anti-estrogen, which can improve the own FSH level, increase own FSH level with external FSH can give better response. Also, DHEA. The pretreatment in some works show that improve the response. In some works show that transdermal testosterone can give better results. Coenzyme Q10 also, not very strong evidence, but still in some works there is. Using growth hormone in most of works show the improvement of egg number and quality, and adding LH or FHCG in urinary gonadotrophins, there is no LH, but there is HCG. But for poor ovarian responders, in some works, we can see that it is improved the results. So, when we are talking about pretreatment, most often it is coenzyme Q10, testosterone, hair, and estrogens. Pretreatment with coenzyme Q10, in this publication, you can see that increase number of embryos increase the number of cryopreserved embryos, and finally improve the result. Of course, it depends on population. This study, you can see that there was no very big number of patients. But anyway, in some case, it may be helpful. And if, for example, patients has only 1 or 2 follicles, and after this pretreatment we receive 3 or 4, of course, we will have much better result. Because with good ovarian responders, this method will not show the dramatic difference. Also, pretreatment with transdermal testosterone. Meta-analysis show that some of published results in favor of control, it means that there is no better result with testosterone, but some of them show that there is the result. Probably because on different kind of testosterone used and different kind of populations, study populations. Pretreatment with estradiol hemihydride in luteal phase also in some scientific publications show the improve of homogeneity of follicular cohort and finally number of eggs and follicles and pregnancy rate as well. In this publication was showed the dramatic improvement of results after estradiol priming. I should say that in another publication was shown that there is no such influence. So probably the difference between publication, it is the different population, yeah? And that's why the results of different authors are different. But me personally, I use this kind of pretreatment when I have not homogeneous cohort of antral follicles, and sometime in second phase of cycle, I give increase the amount of estrogens, and after that, follicles respond more. I have more homogeneous response to stimulation. Okay, what about controlled ovarian stimulation protocol? So for both group, we can say that growth hormone during the ovarian stimulation may improve the result. We can thinking about luteal phase stimulation protocol. We can also thinking about add LH and probably dual stimulation. It means stimulation in follicular and luteal phase. Just a minute, I will switch. So, what about group 1 and 2 of Poseidon classification? When we have unexpected low egg number and decreased sensitivity of FSH, we try to increase the starting dose of FSH. For sure, will be helpful to add luteinization hormone to our patient, also to add growth hormone. I should say that it is still experimental, but a lot of publications saying that it is improve the result. Double or dual trigger may be helpful because it may increase the number of mature eggs. Also, egg banking and advanced embryological techniques. Why we can have low response with good anti-Mullerian hormone? From one side, it may be due to how to say variability of anti-Mullerian hormone. there are different sources of variability of anti-Müllerian hormone, and it may be physiological variability, laboratory variability, but from the other hand, we can have some gene polymorphism, some gene mutation of receptors of FSH and LH, and it may give us the situation when we have not adequate response to normal FSH dose. And in this case, if we have low gonadotrophin starting dose, we will receive asynchronous follicular development, but with higher dose, we will push all this follicle to growing and receive more eggs. Just a second. When we are talking about group 3 and 4, Poseidon, with low ovarian reserve, it is useless to increase the starting dose because only few follicles will respond with any dose. So in this case, probably will be better to try to synchronize the cohort of follicles, and it may be luteal phase stimulation, or in some case, it may be double stimulation in one cycle. And when we compare the stimulation in luteal and follicular phase, we can see that the results are mostly the same. So this method can permit in shorter time increase the number of eggs. So in poor ovarian responders, sometimes luteal phase stimulation may give even better result than follicular phase stimulation, because in luteal phase, sometimes we have better synchronization of follicles. And second point, that there are different waves of follicle growing, and sometime in luteal phase we can see the beta wave of follicles, and when we catch this wave, we can find that we receive more follicles. So necessary to see and waiting, have patience, and then when we have good situation to start. What about growth hormone? Growth hormone improves sensitivity to gonadotrophins, and it may be due to modulating of FSH activity by increasing the local synthesis of insulin-like growth factor. And this enhances the action of gonadotrophins on growing follicle. And we can see that the use of growth hormone improve the follicle number, improve the number of embryos, and finally may improve the probability of pregnancy. Another method which we can use, adding LH. This is our own investigation, which show that using recombinant LH in poor ovarian responders may improve the number of mature oocytes, number of blastocysts, and blastocysts grow more fast. So we have more blastocysts in day 5 than in day 6 with Pergaveris, for example. So adding LH in controlled ovarian stimulation protocol may increase number and quality of eggs, increase embryological parameters like fertilization, blastulation, and we can receive like that more euploid embryos, and like that has more chance to receive as minimum one embryo, euploid embryo for embryo transfer. What about triggering? We have said that this may be one of the strategies to improve the results of treatment of poor ovarian responders. Because if we have, for example, 2 or 3 or 4 eggs, and only one mature, of course, we has much less chance if in comparing if we have 3 eggs and 3 eggs are mature. So when we're using what we call double or dual stimulation, it means that we can use HCG plus agonists instead of pure HCG, sorry, we can see that in case of dual trigger, we can receive more eggs, more mature eggs, and finally more, little bit more usable embryos. So in difficult case, in situation when we have really poor egg number and sorry, maturity, the dual triggering may be quite helpful. When we compare double and standard triggering for normal ovarian responders, there is no such difference because 17 or 19 eggs statistically will not be different, but 2 or 3 eggs statistically it is important. What can we say about egg quality? Now we can say for sure that amount of mitochondrial DNA correlate with age of woman, with fertilization rate, with rate of aneuploidy, and with blastulation. And now there are several experimental techniques, embryological techniques developing, and all these techniques consist on improve the number of mitochondrial DNA. Some of these techniques consist on put nucleus or fertilized nucleus of patient in donor cytoplasm, and some of these techniques consist on put mitochondria inside of patient fertilized eggs, for example. Our clinic working mostly with pronuclear transfer or with spindle transfer. The technique consists on fertilization of woman egg and donor egg, and then we take out pronucleus from patient egg and put inside of empty donor egg. So we have cytoplasm of patient and nucleus, cytoplasm, sorry, of donor and nucleus of patient. And in these donor cytoplasms, there are much more mitochondria, and in some case, it may be helpful and help to our patient to receive blastocyst and euploid blastocyst and pregnancy. These are our results. We has done this technique to 38 patients in 177 oocytes. All of these patients has embryo arrest. It means that embryos developing and then stop 72 hours or 48 hours, but they stop their development. But after this technique, we has very high blastulation rate, 67% with spindle transfer and 74% with pronuclear transfer. We has done 18 embryo transfer and received 9 clinical pregnancy, and now we have 4 live births and 5 ongoing pregnancies. So we can say that results are quite good, especially for this category of patients. But still it is experimental technique. In some country it is prohibited, in some country there is no legislation, in most of country. In our country also there is no legislation. In some country it is permit, so necessary to see the legal part, of course. So, at the end, I would like to say that if you are a poor responder, the chance to become pregnant depends on age, oocytes quality, and also other factors of general health and also genetic of these embryos. Very important to know that better to start before 39 years old. After 44 years old, generally, whatever we will do, the result will be very poor. Pretreatment with coenzyme Q10, estrogen, testosterone, and other molecules may improve the response. It is not the magic result, but may improve in 1-2 follicle, 1-2 egg, but for poor responders, it is important. Protocols with adding LH, growth hormone, high FSH dosage, and sometimes double stimulation or luteal phase protocol may be helpful. I will repeat once more that several protocols describe, and no one can give the optimal result, necessary to see case by case. And mitochondrial donation techniques also in some cases may be helpful, but it is rather the question of poor egg quality than poor ovarian reserve. But it quite often it is go together. So results will be much better if we will try to find individual approach. And thank you for your kind attention, and I'm waiting for your questions.
And thank you so much. Indeed, brilliant as always, very thorough with everything that you have explained. And we are glad that we were able to listen to this. And of course, now it is your time for the questions. So if you have any, go ahead, type those in. There are some questions ready right here. And I believe we can start right away because there were many, many aspects you explained today. And I already see there are different questions on our topic. First is from Sebastian. So who does spindle transfer work practically?
What do you mean who does? Embryologist, or what do you mean?
Possibly, right,
now
Sebastian?
A clinic head of embryological laboratory doing spindle transfer. His name Pavel. I don't know what do you mean in your question.
Sure.
So normally, practically, it is
Okay.
embryologist, but gynecologist should, how to say, found the patient with good indication, because it is not work for all patients, only for patients relatively young with some follicles, should be as minimum 4 or 5 follicles, and age less than 40 years old will be better, and most indication it is development arrest.
Okay. How does it work? Yeah, if you can explain.
How does it work? So there are different method of working with eggs. So spindle transfer, pronuclear transfer, and also we can do like reconstruction of egg, if we can say. So pronuclear transfer, we can take woman egg and donor egg, fertilize at the same time with sperm of husband. Then second day, when we can see the pronucleus, 2 pronucleus, it means that fertilization happened. We take from donor eggs fertilized with husband sperm, take out this pronucleus, and take pronucleus from patient egg and put inside of this cytoplasm, empty, like house it is donor egg, but like brain it is from patient. And we have embryo like that with genetic, mostly genetic of this patient. Only mitochondrial DNA will be from donor, but the amount of this mitochondrial DNA is very low. And mostly genetic will be from this patient. But as cytoplasmic factors will be much better, environment will be much better, so the probability of development of this embryo will be much higher.
Yeah, thank you so much. And as you already showed in your presentation, there are some live births already. Yeah,
we have live births, and this month we have done 3 cases like that. So we continue.
Even this month, three cases.
Yeah.
Okay. That sounds great. All right.
And
And
also
actually,
maybe
yeah.
spindle transfer. This is another technique. It means that when we can see the mature oocyte, we can see the spindle. And this is the place where there are chromosomes. And also put in donor egg. First, take out nucleus from donor egg, put inside patient, and then make fertilization. So we can do also that. Finally, it is mostly the same at the end, but from technical point of view, a little bit different.
All right. Sounds great to hear. Sounds great for sure. And actually, there's one more question on this topic. Yeah. So, do you think those new methods like spindle transfer and others will become standard in the nearest future?
Difficult to say. It is not something which should be done for every patient. Yeah, it is mostly patients with embryo arrest. We have seen the statistic, it is around 6% of all patients, not very high number. So probably not, but from the legal point of view, I hope in 5, 6 years, 7 years, most of country will permit that.
Okay. Thank you, Elle, for your question. Indeed, interesting to. This is something that it might develop, so we just need to wait and see, right?
Yeah, it is okay. It is the working with genes. Of course, we don't know the long consequence. Probably in 15 years or 20 years, we will say that it is not good. But now there is no information which show that it may, how to say, give some negative influence.
Of course.
But from the third hand, okay, this patient has no other chance to have a baby.
Yeah.
It is not because we would like to manipulate with genes, but because no other options.
Yep. And there's a possibility, and it's
There is a
available,
possibility.
right?
Yeah.
So thank you so much indeed for that. Okay, another question from Sebastian. Are you doing DHEA pre-treatment in poor responders?
Yeah, I have done, but last time not, because last time there was a publications that transdermal testosterone working better, but now me personally, I prefer coenzyme Q10. It seems it works better and faster because with androgens it should be 2, 3, 4 months before, but coenzyme seems working more quickly.
Okay, thank you for the clarification. Anne has a question as well. I'm 42, having a donor egg frozen transfer in December, husband DNA fragmentation 2%, donor age approximately 25. What are our chances of pregnancy? Have previously had 4 miscarriages due to poor egg quality.
Good question. If you have done the genetic test on this embryo and you will transfer genetically normal embryo, the probability of pregnancy is around 60-70%. But if you have not, probably you will have a little bit less probability, maybe 10% less, because mostly the percentage of genetically abnormal embryos with donor's eggs is not very high, around 30-40%, maybe 50%. Genetically abnormal embryos does not implant, so if you will transfer, for example, 2, as minimum one of them will be good quality. So probability of pregnancy is very high. But important to understand that, okay, donor age 25 years old, it is great, but it does not signify that eggs are excellent. Donor can have approximately 30% of eggs poor quality from all eggs, and approximately from 10 to 15% of donor can be with really poor egg quality. And some egg donors may have what we call poor cryotolerance of eggs. It means that in fresh cycle we receive good results, but with frozen eggs of the same person we receive very poor results. So this is the question. there is no possibility to predict the quality and probability of pregnancy of this exact donor. Only one way, if there are 2, 3, 4 patients before, has done the program with the same donor and has pregnancy. This is only the way to know that this donor is really good.
All right. And thanks so much. Hope that was helpful for you. If you have any other questions, of course, go ahead, type this in. We have another question on daily dose of CoQ10 or DHEA. So what kind of dose do you recommend?
CoQ10, approximately 100, from 100 to 200. Different articles give different dose. As minimum 60 milligram, but normally 100 till 200. And DHEA 75 milligrams per day.
All right. Thank you so much for that. I'm waiting. Someone was typing, so we just need to wait a minute and see if we have more questions. So let's see. If you have any, of course, you know what to do. Go ahead, type those in. This is your time, as always. So don't hesitate, of course, to ask anything. Nothing yet, but I'm sure that we will have something in a minute, possibly.
Okay, we're waiting. Yeah, it is difficult to say, the problem that when we have a bad response, we always try to do something to improve. But necessary to understand that some cycles may be better than another cycles. If we will do nothing and the woman will come in 3 months, it may be that this cycle will be better and we will have more oocytes. And there are some publications about cycle-to-cycle variability, and it is still 30% in number of eggs. It means that if we do something and woman months and we receive this 30% more oocytes, it means that it may be due to our treatment, but it may be like that because of intercycle variability. So difficult to prove that our activity really improved the result, or it is like that.
All right. So thank you so much for that additional information as well. Okay, just a second. Yeah, for those with low ovarian response, does mild stimulation produce better results? How much dose do you consider mild stimulation?
Look, also very good question and not easy to answer, because what the idea of mild stimulation? From historical point of view, at the beginning, it was the idea when we has long ovarian stimulation protocol and trigger HCG only and ovarian hyperstimulation syndrome, and understand that with ovarian hyperstimulation syndrome, there is no high level of pregnancies and a lot of complications, and so switch on mild stimulation and discover that results are better and okay, it is more safe. But the problem that if we calculate the cumulative pregnancy rate, more eggs we have, more results we will have. And it is linear relations. It means that more eggs, more pregnancy, more eggs, more pregnancy, and till the egg number around 35, 40. So a lot, yeah? The idea of mild stimulation is to do the fresh transfer, because with higher stimulation and higher estradiol number, we have premature progesterone increase and premature endometrial growing and ready to implantation. And we will have asynchronous situation with embryo and with endometrium. And that's why with big stimulation, with high number of follicles, risk of hyperstimulation and low implantation rate. So idea of mild stimulation to less follicles, less embryos, and no risk, and to have fresh transfer. But if we calculate the result in terms of cumulative live birth rate, it means after 3, 4, 5 transfer after one stimulation, better to have big stimulation and, for example, 10 transfers than one stimulation and one transfer. This is mathematical. What about the dose? Dose depends on body mass index, anti-Mullerian hormone, age, and a very good medication named folitropin delta, Recavel, new medication. There is a calculator of starting dose to receive at the end around 10, 12 follicles. So we can use this. There are calculators for gonal, for Puregon. The normal starting dose with for mild stimulation is around 125, 150. So depends on body mass index, anti-Mullerian hormone, and age.
Okay. As you can see, there is an additional comment. Some people think higher dose affects quality.
Additional comment. Just look, higher dose does not influence egg quality. It is proven, but it may influence gene expression of endometrium, high estradiol and progesterone, which appear with high estradiol. And this decrease the probability of implantation and increase the complication during the pregnancy. So this is the main problem. Mild stimulation, the problem that it is difficult to organize that we will receive exactly, for example, 8 or 10 or 11 follicles. It is not like that you add 2 units and you receive 2 follicles. Normally, you give low dose and you receive, for example, 7, 8, and you increase a little bit and you receive 20. So this is the question. And it is always difficult to find this gold dosage. Main idea of mild stimulation to have fresh transfer and to not have hyperstimulation syndrome. Probably some problem with the internet.
Okay. Thank you. Hi, Dr. Halyna. I'm sorry, but I'm right here. Of course, I had a little bit an issue with the connection, but I'm here. Okay.
Okay.
Sorry about this. Okay, so let me just go to the next question. Okay. I think I missed that one. Yeah, here it is. At the age of 50, what food drugs can help to conceive with donor eggs?
With donor eggs. Look, normally donor eggs give more or less the same result in 35 and 40 and 50. The main question is endometrial thickness and general health. So if, for example, you are a little bit overweight, you have high blood pressure, you have increased sugar level, will be good to normalize all that. So has a healthy diet to decrease carbs, have more sport. So necessary to see the condition. Normally, drugs and food not influence a lot in pregnancy rate if we are talking about egg donation. Important to do, if possible, if you still have menstrual function, to do the transfer in more or less natural cycle to have own corpus luteum. And like that, you will have much less complication during the pregnancy. This is important. But if you are in menopause, okay, probably it will not applicable.
Okay, thank you. Thank you for your question, and hope that was helpful. And let's have a look at the next question from Maya. My folliculogram during last stimulation didn't show many small follicles coming through, so it is correct that dual stimulation wouldn't be helpful for me. I'm 35, low AMH for my age, 6.1 picomoles, IVF 1 egg, IVF second, 3 eggs, all good quality, 5-day blastocysts. I'm non-smoker, healthy lifestyle, and BMI, androgen priming last time, and max dose of FSH. I'm now taking 100 milligrams per for ubiquinol. Sorry.
Yeah. Also one of the pretreatment. Maybe do a steam per se. It short the time when we can receive more eggs. It is raised the question to see when you has more follicles and start the stimulation this moment. Sometime it may be in the same cycle. For example, we start the stimulation, receive 1 or 2 egg, and then we can see cohort of little follicles, and just after you pick up, we can start the second stimulation. It will be dual stim. Or, for example, you come for the stimulation, doctor see only 1 follicle, but you come in 2 weeks and doctor see, for example, 5. And this time it will be luteal phase stimulation. So dual stim per se, it is not the, how to say, it is not increase the number of follicles, but sometime during we can catch this second wave of follicle growing, which can be much better than first one. So we can do also those steam.
Okay, thank you. I hope that was again helpful for you. I believe so. Okay, might be our final question for tonight. So thanks for answering my question. The country, it's a comment, from our previous patient. So the country where we are doing the donor transfer, donor is anonymous. I'm not sure if they will tell me if the donor has donated eggs that have led to pregnancy. Yeah. So this
information probably they will give you because you will not ask the passport of this donor, but you can ask about previous treatment with this donor. I don't think that it is any secret information.
Of course, that's something you can ask if you haven't already. I think it's possible to ask at least and see. Okay, I'm just looking. It looks like that was our final comment, actually. But I would like to thank everyone for joining us, for your question, and of course, Dr. Strelko for being with us as well, for explaining everything and answering all the questions as always. Thank you so much indeed. I just also want to say that someone is typing, so just give me a second. If there is another question, I think we can still. Okay, no worries, of course. Maya, don't worry, it has been recorded, so of course you will have a chance to have a look at this webinar tomorrow. It will be available on myivfanswers.com, but also on our YouTube channel, so don't worry, because Maya has said that she lost connection. We had some issues ourselves, so it's okay. Thank you so much indeed, everyone. Before we finish, anything else, Dr. Strelko, you would like to add?
Thank you for your kind attention. I hope it was useful and interesting for you, and I'm ready to answer your questions. If you have another, please write, and see you soon. Hope.
Yes, we will definitely see you soon as well. There is another upcoming webinar on the 15th of November, if I'm not wrong. So Dr. Strelko will be back. So I'm sure it's going to, of course, we are happy to have you at any time. And before we finish, let me just add that there was another webinar this Thursday. We will talk about miscarriages, and our presenter will be Dr. Natalia Schlarb from Vista Hermosa. So I hope you will be able to join us and then have some questions, I'm sure. And once again, thanks to Phenomatch for supporting European Fertility Society. And this is it for tonight. So thanks everyone again for joining, for your questions. And now enjoy your evening. And of course, Dr. Strelko as well. Thank you so much indeed. See you very soon. Take care. Bye-bye.
See you. Bye-bye.